Hello, everyone. Welcome to our International Day of Older Persons webinar for 2025. My name is Krina, and today I'm going to be your host on behalf of MDPI. And I'm just going to introduce the speakers, the schedule, and the instructions to engage with our speakers today. But first of all, for all of those who don't know things about MDPI, I'd just like to introduce you to what we do here. So we are a pioneer in open access publishing. We have been on the market since 1996, and up to this date, we have more than 400 diverse and open access journals, to be more precise, 487, out of which 477 are peer-reviewed journals with 9 conference journals. We are supported and we are collaborating with almost 300,000 of academic experts, be it academic editors, reviewers, or authors who chose to work with us, and we hope that they enjoy this experience. The journals that are jointly doing this webinar today, whose efforts are recognized for this event, are listed here. I'm just going to go through them really quickly. So Healthcare, International Journal of Environmental Research and Public Health, Psychiatry International, Journal of Aging and Longevity, Geriatrics, Journal of Dementia and Alzheimer's Disease, Vision, Social Sciences, Journal of Intelligence, Behavioral Sciences, and last but not least, European Journal of Investigation in Health, Psychology, and Education. I want to thank all of these journals for supporting this event. They are all open access journals, peer-reviewed, published monthly or bi-monthly by MDPI. If any one of you is interested in checking these journals out, they are listed on the website for this event, and you can click on their names at the bottom of the page. As far as the instructions go, after each of the presentations, if you have questions, I highly encourage you to put them in the Q&A box. But don't worry, if you put them in the chat, we will take them from there and address them for everyone to hear. If you'd like to speak, you can raise your hand. Other than that, I really encourage you to enjoy this webinar, to listen actively, and to interact with our speakers as much as possible. And speaking of the speakers, this is the program for today. So after my introduction, we'll be hearing from Dr. Ramsey, then Dr. Jimenez Lord, followed by Professor Cardoso Marquez. Then after that, we're having a short Q&A session where they can address all your questions, after which Professor Schofield and Dr. Dawson are going to present their own works. And unfortunately, the program is going to be cut short because we have had to move the Q&A session earlier because Professor Monteiro Jr. is not going to be able to join us today. However, we hope to use this time to talk a bit more and to interact with each other, after which I'm going to close the webinar and also instruct you on how to obtain your certificates and everything else. Now that I have introduced the journal, I would like to invite Professor Ramsey to share his screen and to tell us about his work.
Thank you very much, Marina. It's very nice to see everyone here today on the International Day of Older Persons. Today, my talk is titled Preserving Visual Independence, Seeing Clearly, Living Fully. I'm a vitreoretinal surgeon and a specialist in age-related eye diseases. Today's talk will touch a little bit about an area where visual rehabilitation can help patients who have vision limitations from age-related disease. Our talk will focus primarily on macular degeneration and the value of low vision services. These are my disclosures. The opinions I express are solely my own and not the expressed views or opinions of my employer, Beth Israel Lahey Health in Boston. Today's talk will talk a little bit about low vision, what it is, who it affects, the causes. We'll then talk about the solutions to enable best sight. and the ways in which those who practice medicine can work together to help patients achieve their best vision. And we'll, at the very end, just touch upon some community resources that are local, though internationally recognized and available more widely. So low vision is sight that cannot be corrected with glasses or surgery. Let's see, there we go. About 4 million Americans live with low vision. Worldwide, 2.2 billion people have vision impairment. This includes both distance or near vision. 246 million people have low vision, which we'll talk about, and 39 million are blind. They cannot functionally see. Specifically for the condition age-related macular degeneration, more than 9 million people worldwide will be affected by AMD-related vision loss, low vision, and blindness by 2050. As you can see here, it's not an even distribution across the globe. Some countries are affected more greatly by low vision than others. What is the definition of low vision? Well, low vision is vision that cannot be corrected with glasses or surgery, and the visual acuity is less than 20/70 for such individuals. That means at 20 feet, they can see what a normal sighted person would be able to see around 70 feet. Now, individuals may have mild vision loss, so their vision may be better than 20/70, so technically not low vision, but mild visual impairment. And then moderate visual impairment begins at the stage where low vision begins. That's individuals with visual acuity between 20/70 and 21/60. Severe visual impairment are individuals with even greater degrees of vision loss, vision of 20/200 to 20/400, approaching just being able to see the big E at the top of the eye chart. Low vision can also be defined by central or peripheral field loss. Certain diseases affect the field of vision more than others. The causes of low vision include age-related cataract, refractive errors, some of which are uncorrectable, diabetes and diabetic retinopathy. I know several of our speakers today will touch upon the role of diabetes in advancing aging and age-related decline. Various types of glaucoma can lead to low vision. Glaucoma is a pressure-sensitive optic neuropathy and a very important condition, but today's talk, as it is the most prevalent cause of vision limitation in those at older age, is age-related macular degeneration. Some of us who may be coming from other settings across the world may know that there are other conditions that locally may lead to a great deal of low vision, such as corneal opacities or trachoma in certain settings, ocular trauma, infection, or childhood diseases. But again, today's talk will be focusing about age-related diseases. Now, one of those, cataract, though it's the most common and not the topic we're talking about today, it does contribute to visual limitations in patients with other age-related conditions. Cataract is a clouding of the lens and often can be fixed in many settings with surgery, but when there is a cataract, it may multiply the effects of other diseases that lead to an age-related decline in vision, such as glaucoma or age-related macular degeneration or diabetes. Diabetes itself can even accelerate the causes of cataract. Refractive error, imperfection in the power of the eye, limiting its ability to see clearly, is another factor that may compound low vision. This can be partially corrected or fully corrected sometimes with glasses, surgery in the case of cataract, certain other refractive procedures, even corneal transplant, and in certain cases, visual aids, magnifiers, or even computer-aided tools can assist in people to see who have refractive limitations. But age-related macular degeneration, the topic of our talk, is the leading cause of vision loss above the age of 65. It often leads to a loss of central vision or the sharpness of vision, and it may lead to blurry or wavy vision as a result of distortions in the retina from aging. The problems people experience with age-related macular degeneration include decreased reading ability, adjusting to light or dark or night vision problems, which is one of my areas of specialization, or having difficulty with other activities, including driving. The types of macular degeneration, it's a spectrum of disease and a heterogeneous set of conditions. But there are certain telltale signs that the eye doctor or ophthalmologist or optometrist may appreciate. Here in the center of the retina, known as the macula, is what we use for our highest acuity vision. In the early stage of the disease, small drusen-like deposits, little yellow deposits under the retina, leading to distortion of the retina occur. These accumulate in greater number, and when they reach a certain burden, lead to a stage known as intermediate disease, at which time there may also be pigmentary abnormalities or even loss of some of the retina or its structure. And then finally, advanced macular degeneration. The orange kidney bean shaped portion here is an area of what's known as geographic atrophy, a part of the retina near, in this case, to center vision that has been lost with aging. And here we see a hemorrhage in the retina, so-called wet macular degeneration or neovascular disease, where there's bleeding or leakage of fluid into the retina. 1 in 10 Americans above the age of 80 experience vision loss from age-related macular degeneration, and neovascular AMD. This accounts for 15% of the advanced stage of the disease, but it accounts for 80% of vision loss. Thankfully, this is treatable, and it is a condition that can be prevented. For individuals for whom it is appropriate, the National Eye Institute of the United States has helped develop and get approval for the ARADS vitamin supplement. This is a nutrient formula recommended to help reduce the risk of progression in people with intermediate to advanced AMD. So not everyone needs eye vitamins, but if recommended by your eye care provider or a specialist, vitamin supplements can be very helpful at preserving vision. It's important to consult your eye doctor or eye care professional to determine which supplements, if any, are right for you. Shown in the middle panel here is a device which was developed in Boston by our near neighbors at Tufts University, known as an optical coherence tomography scanner. This is a device that allows us to scan the retina, and it allows us to see the retinal structure in near anatomical detail. And we can detect with this disease the loss of tissue, the progression of macular degeneration, and shown here in this panel, this small choroidal neovascular membrane that may be the source of bleeding or exudation, so-called macular neovascularization. Patients between exams with their eye doctor who have age-related macular degeneration are encouraged to check their own vision. Often an Amsler graph paper is sent home with them. And when a change is detected, a distortion when using one eye at a time to check this graph paper, or similar things in the environment to look for the bending of lines, that could be the telltale sign of a change in the disease state that should prompt a return to the eye doctor. When neovascular age-related macular degeneration develops on a daily basis, and it will be much of the part of my day today, we deliver medications to treat vascular endothelial growth factors, which are elevated in this disease. And by injecting medication into the eye, we have the capacity to preserve vision. Treatment can sometimes reverse vision loss associated with the disease and can slow the progression of the disease, but vision often continues to decline with the progression of the disease over time, and even with treatment, many patients may go on to develop levels of low vision. Now, one of the things we won't talk about today are the medications that have recently been developed and approved to treat advanced dry macular degeneration. They don't show the same effects at slowing the progression of vision loss, but they certainly are very anatomically successful. And there's great hope and promise for individuals with so-called dry macular degeneration. But what I want to point out in today's talk, which is one of the most important public health messages to deliver related to those with vision loss, is the importance of a low vision examination. This is an eye exam performed by an optometrist or an ophthalmologist to evaluate the visual system to help an individual optimize their vision, to diagnose and prevent eye disease, and to counsel and refer patients for services. Low vision evaluation is performed most often by a specialist in low vision, the vast majority of whom are optometrists who are our partners in vision care. They perform a thoughtful distance and near vision refraction, supplemented by vision rehabilitation and other therapies, including mobility training and activity training to help people get the most out of their vision. How do we deal with low vision? Well, to maintain our independence at home and in social situations, often there are aids that we use. These could be specialty glasses or magnifiers. There are tools that can be used to help individuals drive with low vision, and I'll touch upon that. And then also often we use magnifiers to improve reading comfort or speed. Shown here is a very simple bar magnifier that can help enlarge text to make it easier for people with limited vision to read. Hand magnifiers, often that are illuminated, are an important set of devices. High-powered reading ads, where a magnifier is usually placed in front of the better seeing eye to aid an individual with vision limitation to see. And when possible, technology can be used. By Timon Group, various different stand magnifiers, you can put a text, a book, an object under this computer-aided vision system to allow the magnification and change in contrast to help individuals see. Driving with low vision is often something very much on individuals' minds. In Massachusetts, where I practice, visual acuity must be 20/40 or better for an unrestricted driver's license. And daytime or daytime only licenses are available for individuals with visual acuity of 20/70 or better, just at the threshold of low vision. Between 20/80 and 2100, some states allow the use of bioptic driving programs or telescopes to help people who have other more severe limits drive. And of course, for all individuals, a visual field must be at least 120 degrees, and it's required for all levels of driver licensure. The states in the United States that permit the bioptic telescope include the state of Massachusetts and many other states. This is a device with the tilt of a head that allows an individual with limited vision to be able to see with high magnification into the distance, and then by tilting their head upward through the glass, see normally through that in order to operate a motor vehicle. There are many non-optical solutions that help individuals with low vision. This includes books on tape, talking watches, many different devices that can help us engage and work within the world, writing guides, tactile bumps, reflective tape on stairs, and then something even as simple as a gooseneck lamp illuminating behind an individual can enhance contrast and aid with reading. Two of my most favorite devices to help individuals with low vision include hands-free magnifiers, the so-called Max TV glasses. These are independently focusable lenses for individuals who have visual limitation. These are devices that can be tuned to help see a TV, a sporting event, and they're rather cool looking devices compared to many other devices that might be used. And then, of course, tablets and smartphones, sometimes enabled with software or even artificial intelligence increasingly to help identify objects to read or see within the environment. Now, what I want to talk about today is the importance of low vision rehabilitation referral characteristics in age-related macular degeneration, the importance of referring to low vision individuals who have visual limiting disease. This is something that's very often overlooked. Low vision rehabilitation services improve visual function and independence. Many eligible patients, however, are not referred for these services. So this was a quality improvement study that we conducted at our own medical center to determine the factors associated with low vision rehabilitation referral to improve visual outcomes and try to determine what happened at completed evaluations. This was a study that we conducted in our large academic combined ophthalmology and optometric practice. There were over 560 patients whose records were reviewed, and we looked at the outcomes of low vision services delivered to these individuals. Factors associated with referral were identified, and we then assessed both the visual and economic outcomes of low vision rehabilitation. Factors that predicted low vision referral. Well, low vision, if you had qualified low vision, that increased by 3.2-fold the chances of receiving a referral. Individuals with bilateral neovascular age-related macular degeneration had a much higher chance of being referred for the service. Certain insurances within our United States, including commercial and Medicare insurance, did have higher rates of utilization as well. But we were crestfallen to find that only 20% of patients that could have been or should have been referred actually were documented to have received referrals for these services. For those patients who the ophthalmologist or optometrist referred, 86% of those individuals who are recommended to the service did complete a low vision referral visit. So if they were referred, they were very likely to go, although there may be a selection bias. What were the outcomes of these referrals? The visual outcomes, more than half of individuals achieved improved best corrected visual acuity. About a third or more than a third gained 2 lines of vision on the eye chart. And half of patients who are at the threshold of being defined as having low vision technically no longer had low vision after being seen by one of our specialists. who are able to improve their vision by giving them a very careful refraction of distance and near. What were the economic benefits estimated to have occurred by the services delivered? Well, the average visual gain was rather modest. These are individuals with age-related vision loss. Macular degeneration is not a disease which is curable, but with the assistance of a low vision specialist, the amount of visual acuity gained translated into quality adjusted life years gained per patient. Vision can be translated into quality adjusted life years. The cost, even at this modest level of vision recovered through these services, was about $3,500 per quality adjusted life years. For those of us who know the value of quality adjusted life years, this is a bargain. And the net monetary benefit for visual rehabilitation services delivered was estimated at a gain of over $700 per patient. So after all the costs were taken account of, this yielded a net benefit to not only the individual, but society at large, given the improvement in visual function achieved by these services. So in conclusion, low vision rehabilitation improved best corrected visual acuity and as a result, vision-related quality of life. It's a cost-effective compared to other therapies we may deliver. It doesn't in any way limit the value of those other services. I inject on a daily basis very expensive medications into the eye in order to preserve vision. But partnering with low vision rehabilitation specialists, vision can actually be enhanced by the delivery of those services. They are underutilized by patients. In a setting with high resource availability, even in this setting, we found that many patients do not access or are not offered even the services. So the goal of my talk is to increase provider awareness, whether we are eye doctors or eye care professionals. If we are caring for the aged, it's very important that we enhance referral to these services, to tell our patients that they exist, to address any insurance disparities or patient barriers. Often we can work out ways for individuals to receive services who may otherwise face challenges, and it's important to integrate low vision into the routine care of age-related macular degeneration. At our practice now, we ensure that all patients who have macular degeneration their providers are notified. And of course, not all patients want to receive these services, but everyone should be made aware that they exist and are available. Now, what are the resources that are available? Now, not all of us may have at our disposal in our local communities low vision rehabilitation services. Some individuals may be able to travel to internationally recognized centers, such as the New England College of Optometry or the Carroll Center or the Perkins School, which are three of the best local institutions within the Boston area. In our country, we also have a commission that helps individuals receive services within their home and have better access to care. But across the globe, there are local Lions clubs and senior centers. I myself am a Lion, and I encourage partnering with our Lions International to get services in many of our communities for individuals who have visual limitation. And then, of course, there are web-based organizations. Hadley.edu, which is a partner of the U.S. National Eye Health Education Program, is an outstanding internet-based service delivery organization. I'd encourage this web address to be shared with any and all who may have visual limitations, as the educational programs and assistance provided is very meaningful. These are the references that support the talk, including some of our own publications. And I'd like to acknowledge my co-authors in the work who have helped to raise awareness and improve the service delivery within my institution, most especially our low vision specialists, Pierre Pellerin and Richard Petroni, and my research partner, Nicole Ross, who's down at the New England College of Optometry and Low Vision, and of course our division chair, Dr. Rowe. Thank you all for your kind attention, and I appreciate all that you do to help those with age-related challenges, both in vision and other parts that we'll hear about today. Thank you.
Thank you, Dr. Ramsey, for this eye-opening presentation. I really enjoyed knowing more about vision and the elderly struggles. If you have any questions for Dr. Ramsey, you can leave them in the Q&A box or in the chat. I think he will try his best to reply before he goes. But if you don't catch him at the end during the Q&A session, please feel free to contact Dr. Ramsey via email, which can be found on the website of the the event. Now, moving forward, I'd like to give the floor to Dr. Jimenez Lord, who will talk about the double jeopardy of pain and dementia.
Thank you very much for MDPI and Geriatrics for the kind invitation to be part of this panel in such a special day, not just because of professional reasons, but also for personal reasons. Our parents are all, our neighbors are all, and we are all of us aging. In the context of decade of healthy aging, I will introduce to you to PEG 15, a meta tool for pain assessment in the old people, and especially in those that are cognitively impaired, especially dementia, and the double jeopardy that pain and aging and dementia can represent. I'm a full professor of psychiatry at the Department of Psychiatric and Forensic Medicine at Universitat Autònoma Barcelona, and also at the Institute of Neuroscience. The decade of healthy aging has arrived after the amazing context of individual and social novelty of aging. In just one century, from the last century to 2000, we have been able to live a half a century more. This can be vain for us, but in the current days, but those that are now 80 years old, they can have them a chance for the first time in their generations to live longer than expected. Our main concern as a society is that this extraordinary achievement for individuals also represent, in some contexts, that social novelty is the ranging, the socio-demographic structure, and how we are able to hamper all the needs and to achieve all of those advances to guarantee a quality of life. In fact, 2020, the number of old people more than 65 exceed than that of children of younger than 5. Spain is one of the countries with higher life expectancy. So in our case, this is a worrisome scenario. It is also for global burden of disease and an aging population that will focus on countries that are underdeveloped, or they have middle to low or middle income economies. So 80% will be located in these areas that now sometimes, at least for dementia, they even hardly are present in the maps. So the socioeconomic impact will hit those that are in the worst conditions. And the quality of life will not just focus on that of the people that is aging, but also on family caregivers, both informal and professional. So there is a paradox. In front of this individual and social novelty of aging, in this amazing increase of life expectancy in global aging population, we will also have higher prevalence of comorbidity and functional deterioration, an increase of burden of disease, assistance needs, and long-term care. So the complexity is adding an extra level of worrisome scenario. Is because we still don't fully understand the complexity of the aging process. And we still don't understand perfectly well how is the continuum between normality and pathology. This group of age has a strong heterogeneity, different kinds of clinical expression, and very difficult ways to make differential diagnosis. So comorbidities, treatments, and acquired functional reserve are struggling to provide at least a guaranteed quality of life. So in the presentation of this event, MDPI just focused not just in this significant increase of aging population, but in the key words that now the United Nations are working with, which is dignity, inclusion, and well-being. Next one, please. So if we look at which are the actions of this decade, it's combating ageism to make age-friendly environments, but also then focusing on integrated care and long-term care. In these scenarios of care, we find that cognitive decline, depressive symptoms, anxiety, pain, and suffering are major issues in most of the scenarios. And then among the facility factors, we can find education and training. So this is part of our goals, just to try to describe this, the interaction between this pain and cognition in a way that it's not the common one. Most of us, we know how much pain can interfere with our mood and our condition, but little is known about the opposite direction, how much cognitive impairment is modifying perception and expression, and for the other ones, detection. Next one, please. So the pain in older people also has all the conditioners. For themselves, there is a world self-report. All people just consider pain is part of their life, because most of the disorders or diseases that are age-related, they can imply some kind of pain. Also, pain has sometimes such a strong impact on the course of disease that can even prevail or have an impact at the cardinal symptoms of that disorder. And there is a more incidence of side effects and adverse effects of treatments for pain or the treatment, and a smaller therapeutic window. So this makes that the pain in older people is in the scenarios where diseases are not expressed as an acute presentation, but chronic presentation. Makes the silent epidemic, as Domenico and Ransen this label to be a worrisome scenario that cannot be dismissed. Most of the disorders, either the implied nociceptive or neuropathic pain. But we are in a good time for pain, as much of the novel understanding of pain has made important changes in the last 10 years, I will say. The first one is that the new classification of disease 11 has considered pain not just a symptom, but a clinical entity by itself. Second. Next one, please. And the second new advance is that once we have improved our conception that pain is not just nociception, that pain is not just the biomedical condition, but also it has an impact on physical experience and psychological experience with sensory and emotional contents, and has become a psychological construct. Next one, please. Now we have gone a step further in the last 5 years with Raha paper that said we have to go further. It's not just a psychophysiological experience that goes beyond nociception, it's that it's a complex and multidimensional experience that affects sensory, affective, and cognitive, and that can lead to physiological, emotional, and behavioral responses. But most importantly for us today is to refer that in this description of Raha, they say that verbal description is not only is not the only way to express pain, and most important, that the inability to communicate pain does not negate the possibility that somebody is suffering. Next one, please. This is terribly important for us in the context of dementia or cognitive impaired people, because most of them, they will not express pain in words or numbers as we are used to do. So most of the clinical context and personal context and caregivers context have a confront a lost verbal communication of pain in other people with dementia. Next one, please. How can I measure something that is not saying the same words that I do? Just next one, please. Next one, please. So if I don't express in the same way, I cannot see that something was there. Next one, please. So pain in cognitive impairment puts us in difficult scenarios. I will describe two of them. One is in a nursery home when a new nurse arrives and has to deal with an old person that is wandering and is clinging to care and is crying for help. Just asking for advice to colleagues, the colleague says that she or he may be on pain. Just a small prescription, verification of pain and prescription of painkillers solve this troublesome scenario, behavioral scenario. The next one, please. Another scenario, real scenario, is living with dementia. A daughter that just because she's aware of that all people with dementia may not express pain in the standard ways and not even being able to say, yes, I have pain when you ask them, so that the daily life habits and some significant events like going to pick up a fruit of the tree, that is something that is a very pleasant, very motivational for the father, can't be corroborated in the face expression of worrisome expression and some frowning of the eyes. Just this was enough to ask for caregivers, professional caregivers or the medical nurses to come and to check. And the final clinical report was that that old person with dementia had acute perforated gangrenosus cholecystitis that needed a hospital admission and emergency laparoscopic cholecystectomy. Next one, please. So we are talking about that it's not just a pain matrix of the elderly or pain or on dementia, that it's more complex. Not just about nociceptive and biomedical or neurobiological scenarios that are terribly complex and different. Next one, please. We are talking that also we have different kind of cognitive impairments that will make the expression of pain to be different from one disorder to another one. Next one, please. And that in the context of dementia, specifically on Alzheimer's dementia, the clinical pattern of our patient will not just be a memory impairment. It will also imply to have symptoms like similar to those of psychosis in 20–40% of patients, sanguine behavior, agitation, aggressivity, and anxiety. That will make our differential diagnosis for pain be very difficult. And this umbrella effect means that also the disease is changing through the years. So what is valid of our understanding how the person expresses pain can become more and more difficult because of the advance of the disease, but also of the loss of verbal expression. Next one, please. So what we know is that there is a high prevalence and needs and challenges to pain diagnosis in cognitive impairment. And this is mostly in the scenarios of nursery home where more of 80% of people has dementia. We also know that this pain will not just imply discomfort, but burden of physical and psychological and social levels. And most importantly, that pain is infradiagnosed and is infratreated, and that probably the tools that are used for clinical registration of pain is not more valid in any of these scenarios. Next one, please. In most of the cases, this undertreatment can be even worse, can be a mistreatment when the symptoms of aggressivity or behavioral alterations make a confounding factor and can be understood as some dropping into psychotic symptoms. And treatment of election can be antipsychotics. There is a white paper 2008 that highlighted the warned all clinical scenarios with dementia to be very careful on pain detection, just to discriminate in differential diagnosis what was due to this kind of neuropsychiatric expression of dementia or due to pain. Next one. And this is also can be considered as involuntary ageism. When we have an old person with a kind of disorder that is less treated just because it's having dementia. That is why we say we have a double jeopardism, because we will have higher people with aging and dementia and comorbidities, and less opportunity to do the good election of treatments if we don't care about how we are registering or recording this pain and how we are doing pain management. Next one. So, and this is just, we are going now to the second part of the talk where I will introduce you the cost action, where Pat Schoffel, that is here today, and me, we were participating. It was an action driven by Stefan Luchtenbachen from University of Bamberg, that the main objective was to develop a comprehensive and international risk tool to assess pain in adults with cognitive impairment, especially dementia, with 5 grouping groups, specific of each kind of the dimensions of this problem. Next one, please. Next one, please. In this scenario, we requested ourselves, do we have any clues that is there a way to measure pain in a very clear way, even if the patient is not talking? Next one, please. And then it comes that from our experimental research with animal models of Alzheimer, mice and rats that have inherited the genes of Alzheimer and have familiar Alzheimer disease. The mice don't talk, and still we are able to do a perfect correlation on how pain or sensory motor function are worsen with age, and how much behavioral correlate of coping with stress strategies or neuropsychiatric symptoms are disarranged in clinical scenarios of dementia. But still, we are able to measure pain, for instance, with tail flicking test, which is just how the behavior of animal express that is pain, even when the other parameters cannot be recorded. Next one, please. Our second finding with Tony Canete is that the first one with cold pain in the tail flicking, in this case is hot pain. Most of the old people get burned, and some of them you have dementia. This is a very common scenario. In a general manner, can we say that people that has dementia still have pain preserved? We can just use the knowledge how we care for the sensitivity of animals to hot, and then we see that both males and females behave differently, but what is sure is that pain is preserved, both in the sensory discriminative dimension and also in the affective emotional, and it does in a gender manner. So females are more sensitive to sensory discriminative pain, and males are more to the affective emotional dimension. Next one, please. In the last slices, I will just present 4 items. The first one is how we can approach this problem. The first immediate tool is just to ask experts, ask the common daily life clinical activity, how they confront which are the needs. This is the panel of Spain. Next one, please. And it was similar in other countries. And what is sure is that everybody feels comfortable using dimensional scales for pain intensity, while multidimensional scales that measure the other components are less used. Next one, please. Most worrisome is that none of these scales is useful when dementia is strongly established or in the more severe stages. So while moderate or middle cognitive impairment can be more or less have a good rate of success, when a severe cognitive impairment on dementia is there, the ability to detect pain is very poor. It drops down to -40%. Next one, please. So from our surveys here in Spain and other countries in Europe, the concerns of clinicians was that the tools have low feasibility and they are very time consuming. And another aspect, when we make open questions for them to express themselves, not in a checklist, but what they really think about, is that they say that they are poorly standardized, they are poor guidelines and very poor recommendations. And there are very little chances to education, most in the training education. And but when they have they have a good satisfaction of that. Next one, please. This is similar in the work done by Pat Schoffel in the different countries of Europe. Next one. Well, all clinicians agree that pain education is required, that we need to design standards and assessment tools. We need to improve how these tools can be used, and we have to make it sure that all the countries are in agreement with that concern and that way of establishing the guidelines and tools. Next one, please. So that's why in different clinical contexts, in this case in Germanas Hospitalarias, at a day hospital or day centers, sociosanitary centers. Next one, please. When we requested if they will want to be involved in meta-tool analysis, that is to pull all the scales we have for pain in dementia and to try to check from different countries which items of all of these scales are the most useful. The Spanish people, as other people in different countries, agree to make an effort and to introduce in their daily life clinical practice some research. And this is the result. We have 2 works that are based on observing pain in all the people with dementia, and then try to see which is how useful they are. We are really very, very driven by daily life clinical practices. Kind of check pain during the time, not just when I have to check a coronary recorders, but is there any clue during life events when the person is doing some training or environmental enrichment or cognitive enrichment when they go to our office or to our desk? Can we check when they are looking just on the corridors that there is some pain there? Next one. So we just check, we pull all of these items from all the existing tools, and we finally, after the screening, we decided to put only 36 items, 15 for facial actions, 10 of them for movement of the body, and 11 for vocalization. Next one, please. And we ask all of our nurses to check them on people on their standard clinical practice, either in the sociosanitary system or in the day hospitals, to be very useful, with usability. Next one, please. And finally, to check if one nurse and the next one will measure exactly the same, how much reliable is inter-observer one day in the next one in rest position or in moving position. Next one, please. And finally, we also decided if we just push here in the shoulder and we make a small pressure, could be able to detect on the face of the person that is some pain and which part of the face that specific person will move. Maybe just this part of the eyes, maybe just moving a little bit the mouth, very small movement that can be detected for each person specifically. Next one, please. The result of these efforts make that finally from the 15 countries that were participating, we discriminate which were the 50 items that for facial expression, movements, and vocalization, the 87 people with dementia were sensitive to change, 27 people with intellectual disability, also 12 people with Huntington disease, and in contrast to 60 people that were cognitively intact. Next one, please. But just making a tool is not enough. Just agreeing in a tool is not enough. We have to do medical education, nurse education, caregiver education. And for that, Ghost Action has established a number of videos to train people how to detect frowning, narrowing eyes, raising upper lip, opening mouth, or looking tense. Next one. There is, in the website, there is a short course for training with the different scales translated to different languages. Next one. And this e-training can test scenarios that are real scenarios. Next one, please. And of course, the previous one. And of course, we also introduce that in our academics. The university takes a role in this to promote that all our 700 students per year that are in the second year, in our case, for medical school nurses, medical physiotherapists will learn about it. And the findings and the opinions of the students before and after this course are exactly the same as those of clinicians in the surveys. Next one, please. So finally, as a summary, we can make a diagnosis, how is the clinical needs for clinicians or caregivers. And they will tell us which are the more difficult scenarios and which are the solutions they need. how much they can rely on facial expression or verbalization. We can also observe or just test tools as the vision was tested with the different size of letters, how much the person can see, and also how much we can educate to make people, clinicians or caregivers, to feel more self-confidence when they are learning about the pain experiences of the person they love or they care, and how much this can intensify the capacity to detect pain, mostly on the face of them. Next one, please. You can check all the literature in the website where all these and more research reports of the 15 countries are available. Next one. And of course, you are invited, if you are in the field, to contribute to advance in pain, in aging, and impaired cognition. And we have in geriatrics open a special issue expecting your involvement and contributions. Thank you very much. Thank you very much for all attention to the group involved in the clinical part, and also for the current group that is working on Alzheimer's models. Juan, I think, is here on the lecture, and other students too. Thank you very much from all of us.
Thank you so much for your lecture. It was really comprehensive and really informative. Yes, I'm seeing in the chats questions. I just want to ask you to be patient because we are having up next Professor Cardoso Marquez, and after that we'll take a short break for questions and answers. So everyone who is currently thinking about asking our presenters about what they've spoken about, please feel free to share either in the chat or in the Q&A box. Now I'd like to give the word to Professor Marquez, who's invited to share his screen and start the presentation.
Okay. Sorry for this delay. So my name is Mario Marx. I come from the University of Beira Interior. I want to congratulate the organization for this opportunity. It's a great honor for me to show my work during the last 20 years. So my background was not from elderly people. I come from training with elite athletes. But when I start to lecture in the university, I have a lot of students that interested in training with the elderly, and I noticed that some of problems that I noticed before with elite athletes were the same with the elderly. So I studied past years, last maybe 15 years, what is the effect of load, the training load on performance. So now I changed to start to study the load or the external load on the improvement of quality life of elderly people. So my talk is velocity-based resistance training in older adults, the importance of velocity losses. So first I am going to do some general introduction to the subject, and then I want to present some of the research of our lab. We have a lot of research on this field, but for today, I only show 5% of our research because it is very, very complex. Okay. So we know that in early life, we have a very broad development. We have good energy, strength, etc. Then after adult life, more or less between 35 and 45 years ago, we start to decline a little bit. We lose some strength, some mass. We're starting to have slow movements, etc., etc. And then the focus of this chat is that in the older age, maybe after 65, 75 years old, we start to decline. So my goal with my team is more to prevent and sometimes to mitigate this decline, because we show that decline on not only in strength but also in muscle mass had a lot, not only implications on daily tasks like walking, go to with the grandchildren to the park, etc., but also they have endocrinal problems, hormonal problems, etc., that can lead to another health complication like cardiovascular complication, AV problems, neural problems, dementia, etc., etc. So we start to look this more carefully because most of programs that are in literature, maybe 90% of programs, when they are prescribing load, external load, they don't know what exactly the load. So our lab want to know what exactly the load, it meaning what the real effort is in terms of physiology. Okay. So, for example, if a doctor has in his office a very simple tool, for example, we notice that the hand grip strength in many women. If you look for this data, we notice that after 60, there's a decline in strength in hand grip strain and especially in men, more decline in men. Why hand grip strain is an excellent tool? Because hand grip strain has a lot of correlation with health, with longevity, with cardiovascular health, with a lot of specific parameters. If you don't have enough time to have a blood test or a very spectacular or a very expensive tool, if you measure hand grip strain, it's a very simple tool to measure the function of these people in terms of also not the strength, also the strength, but also is mental health. It's a very easy tool. If I was doctor, I in my office have an hand grip tool. So leg extension is more also more correlate with the aging. If you look at it's more pronounced in men and than women. It's more smooth, but also very high correlation. You notice this point and special between after 55 years old. Leg extension power. Okay, power is very predictive of muscle function. I have more data, but I think it is enough. Also, a very easy test is walking velocity, and the same problem. We noticed that the people start, men and women start decline, especially after 60, the sixth decade of their life. Okay. So what you do? We don't do nothing. No, we can implement effective strategies for active and healthy aging. So because we can have, well, the literature is very specific that we can turn this on muscular benefits, on function benefits, cardiovascular benefits, cognitive benefits, etc. So some people, when I say some of my colleagues go to your grandmom go to the gym. Say, oh, they don't want to have muscle. No, muscle is not only eat for image. It's also an important organ. It's a very important endocrine organ, and it's very interference not only in the strength and contraction, but in all our main systems like the vascular system, the neural system, the kidneys, every impact in each organ. So the meaning of this talk is why velocity monitoring resistance training important for adults. We'll see. So this is the most important article of training in the last maybe 50 years. 50 years. Is Professor Gonzalez Badillo, Sanchez Medina. Professor Gonzalez Badillo was my PhD advisor. He's now retired. He's a genius from this stuff. And he noticed that if we control the velocity of for each percentage of maximum strength, have a strong relationship with load. If you notice these are more than 500 elite athletes, and if you notice, all the measures are very with high correlation. Notice here 0.97 for squat and then 9.4 for bench press. And he took all these people and he noticed that for each percentage of 1 REM, 1 REM is the load that you can lift one time, the maximum load. And he noticed that for each percentage, they are a specific velocity. So it means that if you control the velocity, we know exactly what percentage we are doing and exactly what load we are doing. Why? Because before this article, this publication, I call this with my students. There is a after Christ and before Christ. I said after Badillo and after Badillo. So it's a very easy tool to monitor the real effort. So the coach, sometimes you are training with 5 kilos or 10 kilos or 30 kilos. Now he can also add more information and said, okay, you are training with X kilos, with X velocity, and you are include X physiologic effort on the person. This is transform huge because now the coach have notion what the real load. It's a lot impact in physiology and health because it's like a medication. When you go to doctor and the doctor prescribe you 10 milligrams of aspirin, okay, he know exactly what is there. Now he can do the same. He prescribed the load and he said, I'm going to prescribe aspirin of external load. Okay. So what I do with my lab, I study the same thing, but with healthy. And I took the relationship between force velocity relationship, and I noticed that only for two, well, I am only showing you two exercise, leg extension and bench press. They are very common exercise, and I show that for men and for women, there are a very high correlation, 0.94, 0.93 between the load and the velocity. You see it? And for example, in bench press, the same. So we can conclude that the velocity is a very reliable measure to control training. So like Padillo has the same correlations, we notice the same correlations with elderly people. So we can trust on this data. So after this, we start to do experimental randomized control trials. Okay. So we know the movement velocity, we know the level of effort, physiological effort, and after this, we can control the volume and the relative intensity of each exercise. Okay. So with this tool, we more accurate match the program relative load intensity for each individual, and you can perform for each individual what is the necessities of individual. Okay. For example, if you two persons, this is very important. This is what I'm going to say. Could have done a conference for 2 hours on a simple phrase. For example, if you have two persons that are performing squat with 70% of load, the same percentage, and one of the subjects do, for example, 10 reps, and the other guy doing 8 reps, you can say, oh, they are doing the different training or different effort. Maybe yes, maybe not, because I'm going to show you if they have the same decline on velocity or say the same fatigue, they actually do the same. And nobody knows this until last year or 2 years. If they decline the effort, the fatigue that we include in their body is exactly the same. One guy can do 10 or 12 reps, and the other guy 6 or 8 reps, and they are doing the same effort. This is completely new. If they are doing the same percentage of one area, or 70, or 80, okay. But if they do different repetitions, it could be the same effort because the decline on velocity is the same, so fatigue is the same. Okay, this could lead us for another conference. So we can monitorize the session, okay, the level of effort. You can measure the number of repetition for each set, and with a given magnitude of velocity loss, 20%, 30%, 40%. We study between 10 and 50. Normally, the more common percentage of velocity loss is around 20, because most of studies show that most benefits that are around 20. If you go further, we induce more fatigue. If you have less magnitude of velocity loss, you show less fatigue. Okay, and more decline, more fatigue. So if to show this in very quickly, we for example, there are a lot of training programs, but if you took one of these, we test around more than 30 programs. So I'll only show one. So if you do 3 sets of 12 repetitions, 3 sets of 12 repetitions, and each one can do only 12 repetitions, or say his maximum is 12, not 13, not 13. Okay, so he can do 12 repetitions, no more than this. So what we did, we took a load that each person can achieve 1 meter per second, and we measure their velocity. Then you took the program, 12 repetitions. Okay, we saw decline in velocity. Then we have a rest period. Once again, 12 repetition, another rest period, another 12 repetition. And then in the end, we took the same load that we took that people achieve 1 meter per second, and we measure what happens, a decline on velocity of 31.1 meter per second, 31.1 percentage. That we show that this kind of program, for example, induce a lot of fatigue. But if you don't control the fatigue, we don't know what is happening. Now we show that it decline the velocity, for example, here 103 and now 071 for the same load after 3 sets of 12. People sometimes say, oh, it's not a very hard training. It's a very hard training, okay? Because they lose 31, almost 32% of their velocity. And to show this physiologically, we have a lot of parameters, but we don't go further today. If we measure lactate and measure ammonia for men and women, for squat and bench press exercise, what we see? We see a strong relationship, if you see, a key exponential, a key linear, and you can see that there is a strong relationship between the metabolic stress and the percentage of fatigue. So what you conclude, more number of repetitions, more lactate, and more ammonia responses. Sometimes people are in gym and said, oh, I only do 10, 12 reps with a light load, but they don't have no clue or no idea how the stress, metabolic stress. And for elderly people, this is matter. For elite athletes, it's very important, but for elderly people, it's very important because they are more fragile. So we must know what is the stress, metabolic stress that we are induced on their body. Okay. So now I'm going to show you some research after this introduction from our lab. So we start. If you notice here, this is our machines on our gym, and we have some linear encoder that measure velocity in machine, and this linear velocity were tested and was published several articles about their reliable, and so they are very reliable and we can trust on their measure. Okay. So the first study that the literature made was from our lab in this field, was in 2020 by a PhD of mine, Diogo Marques, and we start with a simple control of velocity with 20% of loss, and then after this article was the first, we measure with a less velocity loss to compare both. Okay, if you look this here, with the linear encoder is attached. Okay, both in chest press and leg press. And the program very simple: 2 sessions, 10 weeks of training, 2 or 3 sets of 20% velocity loss, with a load very if you notice, with a very light load. Normally the most articles, and if you look into the guidelines of international guidelines like American College of Sport Medicine, They took more higher percentage. I disagree totally with this approach. We don't need to in elderly to go further, and we show this. And the simple exercise: leg press, chest press, medicine ball throw, and chair squat. What we saw for great increases in maximal strength for both leg press and chest press. We have a great increase in medicine ball throw, and what you conclude, the same percentage of velocity load result in different number of reps between exercise. If you look at this, leg press and chest press, for the same effort, they have different reps. This is very interesting. And if you notice also, 9.7 was the average for leg press and 6.8 for the chest press. And you normal literature, the articles have achieved more reps. So we show that with very few reps, the elderly people can improve a lot. We are talking about people with 70, 75 years old. Okay. So evidence monitoring velocity during strength training is effective and individualize the volume and improve strength and functional capacity in all adults. And the next question is a lower velocity loss effective to improve strength and functional capacity in this population? Or we saw good results with 20%, and they say, can we achieve also good result with 10%? 10% is much less fatigue. Okay, so we took the same approach with same percentage of 1 REM, but with less decline in velocity. The same exercise, the same program, the same kind of data. Okay, and you saw the same increase in 1 REM, the same increase in 1 REM in bench press, in throw distance, in walking. Okay, and you saw here much less repetition, only 5 reps for leg press and only 3.6 reps. If I show this before to people, say, Mario, you are crazy. No, we show that with very few reps, we can achieve great results on maximal strength, on explosive strength, on walking, daily tasks, etc., using a very small amount of percentage. So similar findings compared to the 20% group study. So programming the same velocity loss results in different number of repetitions between exercise. Okay. So evidence, velocity loss of 10% results in very few number of repetitions, yet is a sufficient stimulus to improve strength and functional capacity in all adults. For example, adult which is not very strong or is initiating a program of strength training, you can do these programs with small amount, controlling velocity, control repetition, and I show you that we can still very secure results with no injuries. Programs, they are very short, and people are very happy with this. So the first studies, summary, monitoring repetition velocity in real time allows to individualize program training volume, prescribing 10 or 20% of velocity loss in improvements in strength and functional capacity. Limitations. The mean velocity values associated with each relative load were not determined. These are further investigations. And the load was never adjusted. What I'm going to explain next slide. So we take a next step. So for example, if we control the velocity, like I said in first slide or second slide, we know exactly what is load, what is correct percentage we are training. So what we did in this study, we compared if the mindset of this was we had good results with 10% and 20%. So we took the same two groups, one for 10% and one for 20%, with same percentage, the same extension program for 10 weeks. But the difference here was we adjust the load, which means this, that each session, when the people who are executing the leg press or chest press, they are not in the prescribed load. What we adjust the load. For example, if he's starting to do with 5 kilos, but the velocity was higher. It means that he can do more weight. We adjust the weight in real time. Okay, so we call this ladder adjustment. It was the first time that some literature science took this step on elderly. In the athletes, we saw this, but in elderly, we don't. It was the first article to experiment this. Just load in real time. So we noticed that the program will result in more or less six repetitions per each set in leg press for the VL dash. VL dash the program with a velocity loss of 10% and the other 9.0, and there are significant between these two. And chest press the same. The chest press 4.6 the average, and for the VL20 77. So also difference between these two. So the same relative loads in both groups. VL complete approximately 60-65 total repetition performed by VL test. Okay. So much less repetitions. And we notice that both groups increase. Both groups increase from the pre-test to mid-test. The same VL dash and VL20, okay, for 1 REM, but significantly, this was 74 kilos for 85, 80 for 89. But this is very important. The last 5 weeks, what you notice, they are start to decline, both here more and here less, but they are starting to lose. And what it means? That means that when we adjust the load, probably we induce some fatigue. They are not very well trained, so we induce some fatigue. So they're not only stabilized, but they are starting to decline performance. Okay, we don't know what if this have impact in other skills like walking or other daily tasks, but in strength we saw that they after 5 weeks of adjusted load they start to decline. Here, for example, the same change in prime outcome. We took for the velocity loss 10% and 20%. We took light loads and heavy loads to see if they improve velocity, and also in first week to 7 week they improve 0.5 meters per second for 0.54. Here the same, here the same, here they don't improve, but we notice that the same after the second part of web programs, last 5 weeks, they start decline velocity. That this induce that maybe there are real fatigue on this data, so they can perform real well. This is very important. So and in velocity the first data was from leg press, so we're going to see the same data but on the chest press, and we notice that it was worse. They improve, okay, not significantly. They improve a little bit, not significantly, but they start decline. So the fatigue induced by a just load was much higher effect, much higher dangers in chest press than in leg press. This is very weird because we could expect the inverse, because the legs are normally are stronger, but they have more difficult in upper body. If you look for this data, the same. We took light loads and heavy loads and control the velocity. The same. They improve the velocity from week 0 to week 5. Here the same, very significantly. But after week 5 to week 10, they start to decline. Okay. So evidence in brief. After 5 weeks, an increase of both strength and speed were observed, and these gains were maintained after 10 weeks. Okay, 10% of velocity loss achieved similar results with lower training volume than 20% of velocity loss. So in general, 10% loss of velocity is enough. Okay, adjusting the load during training has caused increased fatigue in the upper limbs. So when you use this kind of approach for upper body, especially in elderly, we must have some cautions. Okay. In brief, what are the acute responses after prescribing different velocity loss during strength training in older adults and functional capacity? What is the real impact of systematic adjustments of training loads in older adult populations? So this is the sum of the subject that we are going to research in next year. Okay. So I conclude velocity is the key. So thank you for your attention.
Thank you so much, Professor, for this presentation. Unfortunately, we don't have any questions in the Q&A box at the moment, and I checked the chat. Apart from hellos and the inquiry about the scale, we don't have anything at the present moment. However, if you would like a short break, we can take one instead of having the Q&A session. If not, we can proceed with the next presentation and read all the questions that hopefully will come at the end. So I am gathering opinion from our speakers, mainly from Professor Schofield, who is next to talk. Would you like a short break or would you like us to continue?
I'm happy to continue if everybody else is.
Okay, in this case, please share your screen and we can start your presentation. While Professor Schofield is sharing her screen, I'd like to yet again encourage everyone to interact as much as possible with our speakers. This is a great opportunity of finding more about their research. It's a good opportunity to tie new collaborations with them and show them the appreciation for their work.
Right,
Yes,
okay,
Mr.
thanks very much for asking me to talk. I'm Pat Schofield. I'm Professor of Clinical Nursing from the University of Plymouth, and I also work as Residential Care Settings Lead for the National Institute of Health Research in the UK. Which means that I link up with many residential care settings, care homes, hospices, and prisons. And I'm going to be talking about pain and aging. So where are we now and what do we need to do in the future? My research for the past more years than I care to remember has been around pain and aging or pain and dementia. So I'm going to share with you some of the studies that I've been involved in. I have no conflicts of interest. So in terms of the aging population, I think lots of people have mentioned this afternoon that we are seeing this massive increase in older adults, both in the UK and across the world. So, for example, in the UK, 10 million people are over the age of 65, and we're going to see a lot more in 20 years' time. 3 million people aged over the age of 80, and that's going to increase to 8 million by 2050. And the pensioner age is increasing, or the pensioner population is increasing, but the younger population in the UK, as everywhere else in the world, is decreasing. So what we are anticipating is that those who are able to care for our older population are actually decreasing significantly. So we're going to need to be much more creative in how we care for older adults going forward. So as I said, across the world, it's very similar. The picture is showing that there is a huge increase in those over the age of 65. And we're going to see 17% of the world's population, 1.6 billion, who are going to be classified as older adults. I'm using the World Health Organization definition here of over 65. So what about chronic pain? This is the work that I've always been involved in, looking at chronic pain in older adults. We know that chronic pain affects adults in general, at a rate of 20%, and that typically what we see in our around 45-year-olds is things like low back pain or fibromyalgia. But as we get older, those over the age of 75, we see this significant increase in chronic pain conditions. And that's things like arthritis or diabetes, your diabetic neuropathies, for example. And the risk factors for chronic pain are associated with aging. So as we get older, our physical activity reduces, and we also see the development of more comorbidities. And then there's things like reduced social networks. So people become isolated and therefore become depressed, which in itself exacerbates the chronic pain. So is chronic pain inevitable? Well, this is a classic, I think, of a patient going to the doctor with pain in a limb to be told it's to be expected at your age. Just leave that a second so you can read it. We did some work quite a few years ago now for Help the Aged in the UK, and some of this was sort of listening events with older adults, and a lot of the comments that were made by older adults themselves was things like, it's expected at my age, I expect to be in pain, or you get used to it and I don't like to complain, I don't want to be a burden. So we see lots of these things coming out in the literature of people's experiences. And I think it's this sort of thing that the experts, the healthcare professionals will know that I'm in pain. I don't need to tell them. I don't want to complain. So why is pain so poorly managed in the older population? What is it that's not happening, that we're doing wrong? Well, there is a lack of knowledge and skills. The training for healthcare professionals, certainly in the UK, is generally quite poor. So, for example, doctors have less than 4 hours training on pain. The most professional group that gets the most training are vets. Nurses, similarly, very few training sessions on pain. So there is this lack of knowledge and skills on how to assess and manage pain. Poor pain assessment and recognising pain. Lydia's already mentioned the whole issue of people with dementia who are unable to articulate their pain in a language that we can understand. So we tend to assume that people aren't in pain. There's a lack of confidence in terms of measuring pain and managing pain, of using drugs and other interventions. A fear of administration or prescribing, the whole opioid crisis, the overprescribing issues come into the fore when we're talking about older adults. In fact, many of the drugs that we use were tested in younger populations and then simply translated across. The assumption that pain is normal, part of getting older, and myths and misconceptions that we have about older adults and pain. Pain is a normal part of age, you'll get used to it. And the older adults perceive pain to a lesser degree than younger adults. If older adults don't complain, then they can't be in pain. And older adults should not be prescribed pain medication because it leads to addiction. Now, we all know that this is absolute rubbish. But we do assume if older adults are not complaining, then they may not be in pain. I did some work a few years ago looking at pain in care homes in largely residents with dementia. but also generally older adults, and using the language pain didn't elicit the response that you would hope. So are you in pain? People don't always understand what you mean by the word pain. So using colloquial language, does it hurt? Is it sore? Does it bother you? Rather than the term pain. Some work a few years ago now by Ty Seal actually demonstrated that discussion on around pain with older adults was around 2 to 3 minutes. Now in the UK we have a 7-minute consultation time, so within that 7 minutes your patient has to explain all of their symptoms, and that's quite challenging for older adults. And this is also influenced by things like gender and cultural factors. So again, it goes back to the language that we use and the sort of expectations that patients have. In the older population, the common pains that we see are associated with arthritis, and those are knee, hips, shoulder, and small joints of the hand, as well as the neuropathic pain. This was work that we did when we developed the national guidelines for pain assessment and management in the UK. And we also know that cancer-related pain occurs more commonly in those over the age of 65. So there are well-recognised pain problems that we see. I'm not going to focus hugely on pain assessment. We did the National Pain Assessment Guidelines in the UK, and I know that Lydia has talked to you about the behavioural pain assessment tools. There is a plethora of literature coming out now around pain assessment and what are the recommended tools and guidelines that we should be using. And these on the slide are just some examples. It is complex, and there is no one tool to suit every patient group. As I say, we published the national guidelines for the UK in 2018, and within those guidelines we recommended the best way to assess pain, we're talking about intensity of pain here, is using the numerical 0 to 10 pain scale, quick and simple, or is your pain none, mild, moderate, severe? But remember to use the language that fits with the patient demographic that you're working with. These guidelines are available on the website if you want to access them. And then in terms of behavioural pain assessment scales, we reviewed all of the pain assessment scales that were available in the literature. I know when we first did these guidelines way back in 2007, there was 7 behavioural pain assessment tools. There's now over 20. So people continue to develop new pain assessment tools for pain assessment in people with dementia, rather than validating the tools that we already have in place and developing the support for using those tools. In the UK, we recommended the Abbey Pain Scale, developed by Jennifer Abbey in Australia. Quite simple, nice behavioural pain scale that could be easily applied into practice. $+ scale that was developed in France by Bernard Wary and his group, well accepted across Europe, but not so popular in the UK. And they also developed the Alga+ scale, which is the acute pain scale. PAIC, as mentioned by Lydia, that scale has been developed and tested in a number of countries across Europe. And PAINAD, an American scale that we now recommend in the UK as being the most appropriate for UK clinical practice. But they're all very similar. They all have similar behavioural indicators. So whichever scale you pick needs to be one that's appropriate for your particular area of practice. One of the things that we did do was develop or incorporate Jennifer Abbey's scale into a pain assessment iPhone application, bearing in mind that a lot of people now working with older adults with cognitive impairment are very tech savvy. So we thought something that would be easy to use, a step-by-step process on an iPhone that could be applied in practice would be quite appropriate. So we incorporated Jennifer Abbey's scale into this pain assessment iPhone application, and it was tested within the ambulance service in the southeast coast of England with paramedics, and they found it very useful as a quick and efficient way of identifying pain in people with cognitive impairment. So in terms of management of pain, I've been involved in a number of research projects in recent years, and I'm just going to talk a little bit about some of those. So funded by the Economic and Social Research Council in the UK, we developed some participatory workshops. So my work involves actually working alongside older adults. What is it that they want to see? And we held these workshops and we talked with them about what sort of things they would like to see to manage their pain. And I'll come back to some of the really interesting things that we found with this participatory workshop. And so ever since that study, I've worked with older adult groups in developing research projects that I've been involved in. So we had funding from the Medical Research Council under the Lifelong and Health and Wellbeing umbrella to look at developing self-management strategies for managing pain in the older population. This was our EPIC study, and it was a 4-year programme of research. So it came from the ESRC study that I mentioned in the previous slide. But what we did here was we surveyed GP practices across the UK. We surveyed pain clinics. We worked with older adults. We interviewed them. We worked with them in small groups, looking at what was available to self-manage pain. And we came up with a number of recommendations that could be used. So these are some of the things that we developed from that study. So the MediKids booklet, this is something that our older adults identified, was being able to talk to the grandchildren, to explain pain to the grandchildren. Why can't they get on the floor and play with them or pick their grandchildren up? So we developed this comic book to explain pain to children. We also developed a number of leaflets around how to find information and also how to help yourself. So what sort of things to use to self-manage the pain. And these sorts of things we rolled out across the UK into pain clinics who were dealing with older adults. Interestingly, a lot of our older adults that we were working with did not like internet sort of approaches. They preferred the sort of hands-on visual things that they could hold and look at. And of course, we had the publications as well. The national guidelines I've mentioned, so the assessment guidelines and then the management guidelines, both available in the literature and online. These were rolled out across the UK. And they're things that we recommended based on systematic reviews of the literature. So, as I mentioned, pain scales need to be evaluated in all different types of settings, and education needs to be appropriate to apply them into practice. Management strategies should be applied to older cohorts. As I said earlier, we tend to pick up things, apply them to younger adults, and then simply translate them across to the older population. And of course, that's not the way to go. We need to grasp the nettle and do the research with the older population. Older cohorts are changing and we need to adapt to their changing needs. So, you know, the 65 plus population now that we're working with are more tech savvy than those previous. So I remember when I did the care home studies, we had the over 80 population who were more into self-management as opposed to the 65, 75-year-olds. And that demographic is changing all of the time. Education is really important for health professionals and for older adults themselves. It's not acceptable that pain is part of aging. It's just not good enough. We need to do something about it to help people cope with their pain. We've recently completed a study looking at frailty and the relationship with chronic pain, and to identify and develop strategies, again, for managing frailty, pain, and improving quality of life. This involved mapping the evidence and exploring the experiences of older adults and looking at healthcare professionals' opinions and co-designing management approaches. So again, this is about working with older adults. We've also recently completed a dementia and dental pain study in care homes, knowing that from work we've done previously, that oral health care is not a priority in many of the care home settings across the UK, and that dental care is often quite neglected. And again, not a priority. And some of the care home managers we were talking to were saying that they hadn't thought of dental pain as being the cause of maybe not eating or weight loss or other causes of distress in the residents in their care. So we did some listening events to bring together stakeholders, carers, residents, and to identify what were the priorities. And these were some of the things that we identified, both from patients and informal carers and formal carers. And from this study, we were able to demonstrate some changes in practice. So rather than identifying a dental problem in the home and then sending somebody into hospital for treatment, we saw dentists actually visiting the homes so that the resident could stay in the home and therefore not increase the risk of confusion or exacerbate their dementia. A study which we've just started this year is looking at issues around prescribing in the older population and to develop a co-designed model of pain management and de-prescribing, if you like. So here you can see from the literature, we know that, as I've said, older adults have multiple comorbidities, many of which cause chronic pain. They're often prescribed many drugs and are not followed up or monitored, and often not referred to pain clinics or specialised services. Older adults often take multiple drugs and have multiple pain problems and don't like to complain. And as I've mentioned previously, 7-minute consultation with a GP is not adequate to have an in-depth pain discussion. And long-term overprescribing, and I'm talking here about non-steroidal anti-inflammatory drugs, some of the drugs like gabapentin or epilim that are used over long periods of time and end up resulting in a major health crisis and hospitalization. Not particularly talking about opioids, it's not a huge issue in the older population in the UK, although there is some overprescribing in some areas. So going forward, what else needs to be done? Well, we're developing a study at the moment looking at major trauma. So injuries such as, your fractured neck of femur, your fractured ribs, patients who come into hospital following a traumatic injury and are then prescribed opioids. And what we're wanting to do is to monitor what happens to these patients over a long period of time and tailoring of the opioids or discontinuing of the opioids. We need to continue our dental pain and care homes work. We haven't yet obtained funding to carry on that study. We're currently working with a number of care homes looking at the use of virtual reality to help manage pain and distress. So we're working in collaboration with some tech people to develop virtual reality programs that could be used with people with dementia living in care homes. And we've identified from care home managers that this would be something that would be acceptable to use in the care home setting. And obviously our overprescribing study will continue. We've got another 12 months or so on that study, and we plan to take this study forward for further funding. You remember I mentioned that I always like to talk to the older population to find out what it is that they want to see. When I first did my workshops with older adults, in some of the early work funded by the ESRC, we thought what a fabulous idea to use the WeFit, the platform that you can stand on and interact with the television to do activities. And we thought this would be a superb idea to enable people to improve their mobility, their function, and maybe decrease their pain. When we suggested this idea to the group, they were mortified. They thought this was a terrible idea and no, we don't want to use it. We'd be frightened of falling. We don't think it would help us at all. And then a few years later, I saw this in a newspaper of an 89-year-old lady living in a care home in the UK using WeFit. And I suppose the lesson there is that the older population is not homogenous. They are completely different with different views and perspectives on what it is they want to use. And of course, digital natives are growing up. The over 65s that we are seeing now are using Facebook, are using technology, the internet. AI is coming in, so this is going to be things of the future. So I think that's an important thing to remember when we're managing any condition with the older population. I've put some references on there of some of the work that I've done, and my email is there. I just want to mention that we are pulling together a special edition on cultural aspects of pain and aging. So we have contributors from North America and Africa and Europe, and we're looking for anybody else who wants to come onto the editorial board, particularly from areas like Asia, because we want to look at, the differences in pain, communication, assessment and management across different cultural or religious groups. So please get in touch if you're interested or you want more information on that. So thank you.
Thank you so much, Professor Schofield, for this wonderful presentation. So whoever's interested in collaborating with Professor Schofield, please feel free to reach out to her. As you can see, she's looking for collaborators. Moving on to the last presentation of the day, Dr. April Dawson is going to talk about diabetes and social needs of older adults. I highly encourage you, yet again, please don't be shy and address your questions in the chat or in the Q&A box.
Thank you so much. So good morning, good afternoon, and good evening to everyone who's attending the webinar. I just want to take a moment to thank MDPI and the organizers of this event for providing me with the opportunity to present and share information about my research on this international platform. I'm truly grateful for this opportunity. So today I'm going to be talking a little bit about the burden of diabetes, focusing on the United States in particular, where I'm located, explain the differences between social determinants of health, social needs, and social risk. I'll go on to talk a little bit about my diabetes social needs randomized controlled trial that's ongoing and about to finish up. Talk a little bit about preliminary results that we found, and then conclude with my future directions and next steps. And before I proceed, I apologize, I didn't introduce myself. I'm here at the Medical College of Wisconsin, and I'm an associate professor of medicine in the Department of Medicine, the Division of General Internal Medicine, and I'm a health services researcher by training who focuses on developing lifestyle and behavioral interventions for older adults with primarily poorly controlled type 2 diabetes. So now we'll go ahead and get started by discussing the burden of diabetes. Around the world, there are about 589 million adults who are living with diabetes and about 56 million individuals living with diabetes in the North American and Caribbean region, which is where I am presently located. In the United States, the burden of diabetes is very high and it impacts almost 15% of the population and is steadily increasing. We know that there are disparities in the burden of diabetes by race and ethnicity, with almost 18% of African Americans or non-Hispanic Black individuals, 17% of non-Hispanic Asians, 16% of Hispanic Latinos, and 14% of non-Hispanic white adults having the condition. In addition to there being racial and ethnic disparities, there are disparities in the burden of disease by age as well, with almost 30% of adults aged 65 and older having diabetes compared to 19% of middle-aged adults around the ages of 45 to 64 and 5% of younger adults aged 18 to 44. It's for this reason, due to the differences in burden of disease, that I have primarily chosen to focus on the older adult population and racial and ethnic minorities to try to address and improve outcomes in these groups. Both older adults and older racial ethnic minorities with diabetes are at an increased risk of micro and macrovascular complications such as retinopathy, nephropathy, lower limb amputations, cognitive impairment, and dementia, and they also have twice the risk of mortality compared to individuals without diabetes. As it has been the topic of today's seminar and the Day of Awareness, we're all aware that the global and US populations are aging. And so with this increase in older adults, we're also seeing an increase in burden of diabetes, burden on the healthcare system as a result. And therefore, because of this, it's ever more important for us to identify new and more effective strategies to care for the older adult and aging population, while at the same time reducing the risk of diabetes-related complications and premature mortality. In terms of diabetes can be self-managed, and diabetes control can be achieved with adherence to self-management guidelines. These guidelines focus on medication adherence, so making sure folks are taking medications in appropriate dosages at the times that they're supposed to be taking them, blood glucose self-monitoring. There are a number of new technologies that help to support this particular activity by way of the continuous glucose monitors, making sure folks attend doctor's visits, are having a healthy diet, and physically active. Unfortunately, the literature shows that African Americans and non-Hispanic Black adults, older adults, are less adherent to diabetes self-management guidelines. And so this point brings us to social determinants of health, social risk, and social needs. Social determinants of health are a very familiar concept and are known to impact health outcomes and behaviors. And so I'm just going to take a moment to define each one of these constructs and talk about how it impacts diabetes and diabetes related outcomes. So this particular slide, on the right-hand side, we have the social determinants of health framework that was published by the World Health Organization Commission on Social Determinants. I do want to start by saying that social determinants of health, they're not positive nor negative. They're merely defined as the conditions in which people are born, live, work, and age that may affect health, risk for disease, and quality of life. And so the framework that's been put forth by the World Health Organization shows that there are structural determinants and intermediary determinants. And so within the structural determinants, we have the socioeconomic and political context of these policies that are at play that in turn will dictate or impact one's socioeconomic position and standing. And these particular structural determinants give rise to the intermediary determinants, such as the behavioral factors that are driving outcomes. And so it's this interplay of factors that impacts one's health and well-being. The structural factors in particular, such as housing, education, job, and healthcare services, are things that we've seen specifically in Milwaukee, Wisconsin. There have been some historical events and historical policies that have placed racial and ethnic minorities at a disadvantage, leading to the disparity in outcomes amongst individuals with diabetes. And so, as I mentioned, social determinants are not negative or positive, but they shape health and health outcomes for better or worse. On the other hand, social risk, these are the negative or the adverse social conditions that are associated with poor health. So, whereas the social determinant might be food, housing, income, the social risk factor is housing insecurity or housing instability, food insecurity, transportation barriers, and social isolation, for example. I do want to take a moment just to reiterate that there is a difference between social risk and behavioral risk. I know some of the tools that have been integrated into some of the healthcare systems in the US will refer to social determinants assessment, but they also are assessing behavioral factors as well. Social risks are intertwined with behavioral risk, and they do shape individual behavior, whereas specific behavioral risks or examples of those include smoking, using alcohol, lack of physical activity, or having an unhealthy diet. And it's modifying these individual behaviors depends on addressing some of the upstream social factors that shape them. So it's really hard to make recommendations to patients about increasing physical activity or having a healthy diet when they're living in an environment that may not be safe to go outside and walk, run, or jog, or they may be living in a food desert and not have access to the recommended foods to support their condition. Now, the last differentiation that I want to make is between the social risk and social or unmet needs. A lot of times you'll hear social and unmet needs used interchangeably, whereas an individual may have a number of social risks at play. It's really what the individual prioritizes in terms of what needs to be addressed in order for them to better care for themselves or better manage their chronic condition. Those items that have been prioritized by the patient are what are defined as the social or unmet needs. So they can have multiple social risks such as housing instability, food insecurity, transportation barriers, but that patient may say, transportation barriers are really the biggest problem and the biggest challenge that I'm dealing with and when it comes to managing my diabetes. As a result, I'm not able to make it to my medical appointments. I'm not able to make it to the store to buy the foods that I need. I'm not able to pick up my medications. And so this is what I want to focus on. This is what's truly hindering me. And so it just really kind of hones in on the importance of using an individualized, tailored, patient-centered approach to get at the root of the problem that an individual might be dealing with. So the image on the right is of Maslow's hierarchy of needs, and this is where we can see that those lower level needs, so the physiological needs like air, water, food, and safety needs, these basic needs need to be addressed before an individual can focus on higher order needs and doing things like managing their diabetes. And so if somebody's concerned about whether or not they can afford their food, if the electricity is about to be turned off, they're going to focus on addressing those things and prioritize that before being concerned about picking up their medications, paying for medications, or getting their diabetes self-care supplies, such as testing strips that are needed. Therefore, and I guess before I talk about the intervention and the study, I did want to, because this is an international platform, just take a moment to talk about what some older US adults are being faced with when it comes in regards to the social needs and social risk factors. When it comes to poverty, almost 10% of adults age 65 and older are living below the poverty level. Just like the burden of diabetes, we do have differences by racial and ethnic groups, with racial ethnic minorities having a higher rate of poverty compared to our non-Hispanic white population. In terms of the housing instability, about 38% of adults with diabetes report housing insecurity, and that meaning a limited availability or inability to acquire stable and safe housing. In a study that looked at older adults with diabetes, the rate of individuals with poorly controlled type 2 diabetes, defined as a hemoglobin A1C greater than or equal to 8%, was twice that of individuals with diabetes in stable housing. And so housing definitely plays a part in terms of glycemic control and diabetes management. However, in terms of addressing the issue, there are some rental assistance programs that can help ease the financial burden and provide opportunities for individuals to try to access housing. For food insecurity, we have seen that individuals with food insecurity are more likely to have an emergency department visit or be seen in the emergency room, be hospitalized, have depression, and have very poorly controlled diabetes with really high A1Cs. And so barriers to managing diabetes within the context of food insecure adults includes increasing access to food, medications, reducing stress, and managing the cost of health-related needs. Finally, in regards to transportation challenges, transportation barriers are known to be associated with rescheduled or missed appointments, delaying care, and missed or delayed medication use. This is another prominent challenge and problem in the US older adult population. We have folks who are relying on caregivers to get to medical appointments and to coordinate their rides. However, again, another opportunity here in our area would be for folks to utilize non-emergency medical transportation that might be available to address this particular need. And so I just want to, make sure that we emphasize, while there are these social problems and social factors, in many instances, there are social services and resources that might be available in the community. And it's a matter of making sure that patients are aware of them, helping them to tap into those resources. And it goes beyond just making that basic referral or assisting with navigation. We really need to do more to help bring that need to closure and to resolve the need for folks to be able to then start to focus on their diabetes management. And so this leads us to our gap in knowledge that we were hoping to address, and just look at what would be the impact of not only providing diabetes self-management education and skills training, but assessing, addressing, and resolving unmet social needs that were identified by patients. So this particular randomized controlled trial is funded by the American Diabetes Association, and we are actually almost finished with the study, I'm very happy to say. We've completed recruitment, we've completed the 3-month follow-up visits, and we have the last set of patients who are going through their final 6-month follow-up period. The study aims for the research were to assess or test the preliminary efficacy of this combined diabetes education and skills training and social needs resolution intervention on clinical outcomes of hemoglobin A1C, blood pressure, and LDL cholesterol, and also on patient-reported outcomes of global health, pain, social participation, and fatigue in older African American adults with poorly controlled type 2 diabetes. In this particular case, we defined older adult as a little bit younger, 50 years and older, and poor control as a hemoglobin A1C greater than equal to 8%. The reason for lowering the age a little bit to include those who are 50 years and older for this particular group is that we know that racial and ethnic minorities start to experience complications at an earlier age. And so we want to try to do what we can earlier on to prevent complications from developing. As I mentioned, the patients were followed for 6 months and had visits at baseline, 3 and 6 months of follow-up. In terms of the intervention, our intervention is being delivered by a health educator who's master's trained and is trained in delivering diabetes self-management education and skills training as well. This individual takes a thorough assessment of the social risk and unmet basic needs using the validated CMS tool for assessing health-related social needs. During that baseline visit, they talk with the patient, and the patient prioritizes the top 3 needs that they would like to have resolved during the course of the 6-month study. The intervention sessions rather, are about an hour, and they're delivered over the telephone. The first 15 minutes of the call are used to provide the diabetes education piece, and then the majority of the time, about 45 minutes, is dedicated to problem solving and social needs resolution. And so the health educator will help patients do everything from obtain applications or forms that are needed, complete the applications and forms for different social services that they need to address their need, submit them, and just kind of help them to navigate that process, attend visits, and do everything that they can to try to bring the need to closure. Patients assigned to our usual care arm are receiving male diabetes education materials based on recommendations from the American Diabetes Association. So they receive print materials that cover the topics of diabetes in general, blood glucose monitoring, medication adherence, the basics of eating and exercise, blood pressure and cholesterol, and then foot, skin, and dental care as well. So now I just want to share some very preliminary results from our study. This is just based on the baseline data that we've collected to date. We're waiting to have all of the data before we do any formal analyses. There were no significant differences in the variables that are presented between the control and intervention arms. In terms of age, the mean age was about 62 years. Education was fairly high, with most of the older adults having completed high school or having a high school degree equivalent. About 11% in control, 20% reported being married. About a quarter of the older adults were employed. This one is really interesting to me, given that, the mean age is in the lower 60s. We still have some working folks who are included in this group. And also our lower age was 50. So not everybody's retired at this point just yet. The cognitive function piece is another area that I just want to kind of take a moment and pause. As I mentioned in the beginning of the presentation, type 2 diabetes is a known risk factor, in addition to age, a known risk factor for cognitive decline, mild cognitive impairment, and dementia. But I was really surprised and alarmed by the fact that we have a large majority of our sample showing signs of cognitive decline. This was not part of our screening criteria, but we did have a cognitive assessment. We use the slums assessment to categorize folks. And so you can see where not only the social risk might be posing challenges to diabetes management for this group, but also the cognitive function issues will pose a challenge as well in terms of achieving optimal outcomes. And then in terms of the social risk and our clinical outcomes, we have again, a fairly large percentage of the sample reporting some level of social risk around housing insecurity, about 17%, 10%, almost 10% between groups. Food insecurity was reaching upwards to 40% of the individuals experiencing food insecurity. Again, something to really just emphasize when we're making dietary recommendations for patients with diabetes. If they're unable to afford what's being recommended, it's going to be a challenge for them to actually comply and be adherent. Transportation barriers was another one with a large percentage of the sample being impacted. And then our blood pressure levels at baseline were pretty good overall. Mean A1Cs were very high, almost 10% A1C for the control and intervention groups at baseline. So that's what we have by way of preliminary data and kind of understanding our cohort a little bit. As I mentioned, as soon as we finish up data collection within the next month or two, we'll start to look at the intervention effect and impact on those outcomes of interest. So in terms of future directions, the next steps for me are going to be complete our data collection, analyze those results. I would like to convert this pilot study into a larger grant to assess effectiveness of the intervention, assuming we have some sort of signal that it's working at the pilot level. And then I also, because of what we're seeing by way of the prevalence of cognitive decline within this sample, consider some strategies to address cognitive decline in this population and start to think about ways that we can incorporate and develop interventions that will hopefully mitigate the effect and improve not only the diabetes-related outcomes, but ultimately, hopefully, result in reducing and slowing progression of cognitive decline. So that concludes my presentation. Again, I just want to say thank you. Huge thanks to our study participants. We wouldn't have this data without them and their time, willingness to be involved in the work. Thank you to my mentors, the research team, the funding agency, American Diabetes Association, and my family who's always supporting everything that I do. My contact information can be accessed via the QR code, and I'm more than happy to place my email address in the chat as well.
Thank you so much, Dr. Dawson. It was a really informative and thorough presentation. Thank you once again, everyone, for speaking here today, for taking the time to grace us with your presence and presentations. I believe that these presentations that you had were really, really educational and helped clear so many of the concerns that we have on this matter. I see that there are still no questions in the Q&A box or in the chat. However, I found a way to try to engage our speakers at least, and I'd like to first propose that if you have questions for one another, you can start discuss amongst yourselves, or if you don't prefer to do this, I'd like to ask you what were like the biggest challenges that you met with during your research with elder populations, or what are the biggest disadvantages of you studying this field?
Just in my case, I will say that the heterogeneity of the older population makes any study to be like 3 times bigger than should be in a younger age. This, when we are doing animal models, we need 12 animals instead of 8. But most importantly is that the time is running. So it's more difficult to work with them, but at the same time, they are on need. And then if it's for any kind of disease, sometimes they are stable, sometimes are not. So it's difficult to inclusion criteria to be continued for them. Maybe they can be included now, but next 2 months later, with the ethical committee approved, the person has changed. And this tell us not that we are slow in the procedure, is that they are on a strong need on collaborative research, on any effort. It's like pediatrician. Nobody will accept that you do a treatment or whatever in a newborn and then you apply later with an older child. So it's the same for elderly, old people. And old people are very, just a word, are very gentle. In our case, our people with dementia, they were eager to participate, to help other people. So I think that these are the two messages. They are in strong need. There is too difficult to fit with the heterogeneity and the progress of disease. And at the same time, they are unique as participants. They are doing the research. They are telling us how they feel and what matters. And I think we have to listen a little bit more what matters for them.
Yes, indeed. So thoughtfully said. I do agree that this is a challenge, them not being here for too long for subsequent studies and also the ethical concerns. And you rightfully pointed that it is the same with younger generations like newborns and toddlers. And this type of research is really hard to get started, but is really important at the same time. Professor Schofield, please.
Yes, I totally agree with what Lydia was saying. I think it has been very challenging to do research with older adults. And it is a cohort that spans 40 years at least. So, it's a huge range of the population. And also for us in the UK, it's not been seen as a priority. So research into aging is not in the top funded priorities. So you really have to fight to get funding in the UK to do research in this area. I think it's changing. It is getting better. But I think we've still some way to go.
Thank you. Thank you so much for your input. Professor Marquez?
I can add something to other colleagues said. I agree totally. For example, in my case, my university is a region of Portugal, a very poor region, and it's very difficult to involve all these kind of people. We have not a lot of research, so it's very difficult. For example, now we're trying to implement 3 randomized controlled trials during 1 year, with blood tests, with cognitive questionnaires, with RME, so scanners to the brain, etc. So the main difficult is to enroll all these people, to connect with their doctors, with their families, to bring to our lab. We talk about more than 200 people, so it's not very easy task. We're a very small university, but the first studies, the people said to us they are very happy with the results. For example, some personal doctors said they are improved. Some take the medication for example, for hypertension or reduce for diabetes. And this is very enthusiastic experts to start this new program, but will be very challenge for us. But the main problem, I think, is to put together everybody, doctors, population, the families, because they are elderly. Some of them are 80 years old and or more, with some dimension. So it's not difficult to control these all parameters. For me, is the most problem is this.
Thank you so much for your input. And I do admire everyone who, despite all these struggles and disadvantages, still keeps on doing research for this field. Professor Dawson?
Yes, I just want to echo what Professor Cardoso was just sharing in terms of like the logistical challenges and the logistical aspect of conducting the research. In our area, we have quite a few patients who actually are homebound or have functional limitations, no transportation. And so our team members, we try to be as flexible as possible, and we will go to homes, we'll go to community sites and meet the patients where they are. But just when you have a pilot study and the budget of a pilot study, it doesn't really support, the mileage. The staffing size is so small. We make sure that folks go out 2 by 2, but if you only have one program assistant, one health educator, it kind of takes away from, other patients and the speed with which you could be getting things done. So that's definitely one of the challenges. And in addition to, explaining the study and convincing folks that, yeah, this is something that's really good, it's really important. I don't know if you all have sometimes challenges with trust in terms of the patient population with research or trust in the healthcare system, but when it comes to older African Americans, older racial ethnic minorities, that's something that we definitely see from time to time here in the US, that there have been atrocities that have happened in the past that people still remember, and it makes them really hesitant to want to participate. So part of what we do is not just the research, but trying to rebuild some of that trust with our community and community partners as well.
Thank you so much for your input. Professor Cardoso Marquez, do you have anything else to add? I see you have raised your hand. I don't know if you wanted to lower it or... Okay.
No question.
I think there is a comment from one of the participants that is very insightful also. I think maybe you can read for all of us as a contribution.
I wanted to read this next. Miss Makovic, I hoping that I pronounce this right, says thank you for the organizing this webinar. Thank you to all the speakers who touched on various aspects of aging. We all agree that education, broadly defined for both older people and caregiver, is crucial, and this education should begin much earlier than in old age to shape early healthy habits and lifestyle, including a supportive environment and social bonds. This is a task and a challenge for all social services in the area of global aging societies. This is a really, really nice feedback that we've received just now, and also allows me to go to my next question. So I asked you about the disadvantages or the challenges, but what about what you find most rewarding about your work? What is it like the motivation that keeps you going?
I mentioned before, I mean, when I see that themselves, they are so gentle. And also because I have a good memory of all people in my family, in my area, my country, in Europe, everywhere. I mean, all people have something special, maybe because when they are old, they can have these intergenerational relationships that United Nations that puts a priority to move on. So just to rely on this intergenerational, I think this is an imprinting. Those who had a good intergenerational cannot avoid looking at their problems. And because our parents are old, and because ourselves, we were talking with Pat, ourselves, we are getting old. So it's a matter of everybody. Everybody should be hopefully all, and they are in a strong need. So this is the most rewarding, to know that if you don't do it, who will do it? It's a kind of, we try to compensate the animals. Now we are in the clinical part. I feel very committed, and it's more difficult than doing rats and mice, I can tell you. It's much more difficult, but at the same time, every single person that participates and you can discuss or talk to the family, whatever, that family is solved. And then the next family, so you count of how many people the research was significant for their lives. This is for me the most rewarding. Then is statistics and papers and everything, but at least everybody that was in the process was done.
Yes, and I see our participant agrees with you. So she says, if not us, who will do it then? Thank you so much for your input. Professor Schofield?
Yeah, I totally agree. I think older people generally, in my experience, want to talk. I think they appreciate being given the opportunity to talk about their experiences. I think they have some fantastic stories to tell, and we don't always give them the opportunity to tell us those stories. And actually, I think it's great fun working with older people, because they're brilliant. They're fun and lots to share, lots of stories, lots of experiences, and I think we can learn so much from them. We don't use enough of that opportunity.
Thank you so much. You got me so emotional thinking about, the elders in my life. So thank you for this input. Is there anyone else that would like to share their thoughts?
Yeah, I would just say, we meet with our health educators weekly to do fidelity monitoring and continue training, and just hearing the feedback and the stories from them regarding, the participants' perspective and how much they appreciate what's being offered. We have a couple of individuals, which I think speaks to some of the points that were raised by Dr. Lydia and Dr. Sheffield, that the participants sometimes are a little bit sad when the study comes to an end because they don't have that health educator to now look forward to communicating with. And so just really thinking beyond the here and now with the research, but how do we start to either implement or have something that's in place that's a little bit more sustainable so that folks will have that constant support that they're looking for and needing. And I think it's almost an indirect way to address some of the loneliness and social isolation that some older adults are experiencing.
Just to complement that, when you were speaking, I thought about those studies where they took some children who are missing one parent or who are living in foster care, and they put them in nursing homes with other adults, and the results were fascinating. And I think we should learn from that experience and do that more often, because conditions may be dire in each and every one of those institutions if they are feeling lonely, and depression rates go up. But since studies show that depression drops and the positive outcomes outweigh, the efforts done to put them together, I think we should just move forward from there and see maybe we can also include some educators, because I feel like they're missing activity in their lives after retirement, especially. Thank you so much. Now I check to see if there are any other hands raised, but I cannot see any. I see that Professor Marquez has left us. Okay, we have one hand raised from one of the attendees. Please go ahead.
Okay, do you hear me?
Yes.
Yes, okay. So I will present myself. I am Khawla Al-Qadi, PhD student in clinical neuroscience, and I am from Morocco. So I will just said I am very happy to participate in this webinar, and it was a very incredible opportunity for to see some research like you or like Dr. Lydia interesting about this subject, and that's it's really amazing and it's really incredible, and it was a big opportunity for a new collaborate in future, because I work in clinical psychological science for a patient with a Parkinson's disease, exactly psychological symptom, anxiety or depression. So that it's an opportunity to me. So thank you very much for this amazing webinar.
Thank you so much for this feedback. I think I speak for all of our speakers that we are glad to see such positive opinions about this event, and I'd like to thank them again for being with us here today and for being so generous with the information. Are there any other questions anyone would like to put forth, or is there any other feedback that you would like to our speakers to know? I assume not. So I'm going to close this webinar by also thanking the participants that took some time out of their time and day to be here today, who had such positive feedback about the presentations. And I just want to remind everyone that the certificates for attendance can be downloaded at the SciForum webpage of this event. We would really enjoy if you could open the link for SurveyMonkey to give us some ratings about this event. And of course, we can, if there is enough support for a second edition, I think we can think about another one. Maybe after our speakers conduct more research. The webinar will be available, as I mentioned at the beginning, on the webpage of the event. It will be recorded, can be accessed in a few days' time. If you need the presentations, the slides from our speakers, please feel free to reach out via email. They are the owners of the presentations, so we are not entitled to give them away, but I'm sure that if you reach out, they will help you. This was Krina from MDPI. I just want to also thank you, Ashma, for helping organize this event, and thank all of the journals that made this event possible. In closing, I'd like to wish you a great day and take care of each other, of your elders, and of yourselves, of course.